Jim Grayson, can you see the screen? Can you see vaccine conversations? Give me a thumbs up. There he is, y'all. I don't know if you see Jim. He's giving a thumbs up. Asante Hiltz, thumbs up. All right, so we are excited you're here. You're in for a treat. We are going to talk about the COVID-19 vaccination. Our keynote speakers are Dr. Peter Huwe and Dr. Joyce Kim. Peter Huwe received his Ph.D. in biochemistry and molecular biophysics from the Perelman School of Medicine at the University of Pennsylvania. He completed his postdoctoral studies at the Fox Chase Cancer Center in Philadelphia. And he's currently an assistant professor of biochemistry at the Mercer University School of Medicine. And he resides in Columbus. His wife, Megan, is one of our providers here at MercyMed. Believe it or not, guys, I did all of that by memory. Also sharing with us is going to be Dr. Joyce Kim. Dr. Joyce Kim is our Chief Medical Officer. She graduated from Case Western Reserve University in 2009 with a BA in Music and Anthropology. She's a great piano player. So if you get a chance to hear her play, you need to ask her to play you some Mozart or Tchaikovsky. She completed medical training at the Ohio University Heritage College of Osteopathic Medicine in 2013. And after a transitional year at University Hospital's Richmond Medical Center in Cleveland, Ohio, she finished family medicine residency at Resurrection Health in Memphis, Tennessee. She was challenged during her time at Resurrection Health to think about healthcare not simply for humanitarian reasons, but as a means to provide excellent medical care for the poor in the name of Jesus. She's equally challenged at MercyMed to work in a way that communicates the love of Christ. And Dr. Kim does that daily for us here at the clinic. I'll also mention we're joined by some wonderful partners, great friends of ours, Dr. Asante Hiltz, along with Daryl Enfinger. They're here representing the Department of Public Health. And apologies for not having y'all's intro together, but we will be hearing from them during the question and response period here in just a couple of few. So a couple of disclaimers as well, everybody, for the good of the order. I'm trying to let participants in. I've got some people in the waiting room. Let me let them in. Dr. Huwe and Dr. Kim are not affiliated with Pfizer, BioNTech, or Moderna, and not receiving any compensation or money for presenting this information. Our motivation here is education. This presentation is for educational purposes. So we really want to reiterate that individual medical decisions should be made between you and your healthcare provider. So this information is up to date to the best of our ability, but some issues are subject to change. So we'll record this, we'll keep this for posterity, but just understand this information is subject to change. And we are, like I said, we're recording this, so be aware of your screen. We are excited to go ahead and get started. So Peter, you can go ahead and take yourself off mute. You want me to take this next slide or do you want to go for it?
I'll take over here. Yeah.
Okay. Lovely. Thank you.
So Joyce and I were chatting one night, and we were talking about some of the misinformation around vaccines and some of the confusing information, and just how it's kind of hard to synthesize all these facts and not facts that you're hearing from so many different sources. And she thought that it might be a good idea to kind of distill a lot of this information and provide it to some of the patients for MercyMed. And so that's what we're going to try to do to the best of our abilities. I'm looking at the people who are here. There's some people who have graduate degrees in science and medicine, and there's other people who maybe haven't taken a science class since the 6th grade. So I'm going to start off by just giving a little bit of the kind of background science behind these vaccines and what you need to know. So just to start off with, your body is made of trillions of cells, about 37 trillion cells. And inside each of those cells is surrounded by what we call a cell membrane. It's kind of like the skin of the cell. It's made of lipids, which are just a fancy word for fats. And inside the middle of the cell, you're going to find another little lipid membrane that's surrounding the nucleus. And that's where your DNA is stored. Okay? And that's found in almost every cell in your body, pretty much all the cells except for red blood cells. You'll find the nucleus in the DNA. And all that the DNA really is at its most basic level is just instructions to make proteins. Okay, so anytime you talk about a different gene, that's just a different protein that gets encoded by the DNA. And proteins are these little molecular machines that do kind of all the work in your body. Okay? So if you wanted to make a protein in a cell, then what your body does is it starts with the DNA, and from that, it can transcribe that DNA into a little message called messenger RNA. Okay? And the messenger RNA will travel outside of the nucleus into the cytoplasm, which is just the area between the nucleus and the cell membrane. And the messenger RNA or mRNA provides the instructions to make a protein. And then your own cells can make that protein. Okay, now the reason why that's important is because these mRNA vaccines are going to leverage your own body's ability to make proteins in order to train your immune system on how to fight a virus. Okay? All right. So if we look at one of these viruses, and this is the SARS-CoV-2 virus you see here, it's got its own plasma membrane, or kind of like a cell membrane, that's made out of, again, lipids, fats, and stuck on the surface of that membrane are going to be its own proteins. Some of them are the M proteins, some of them are E proteins, but the ones that we're interested in are these red ones, the big red ones called the spike proteins. Okay? And you can imagine these spike proteins as almost being like little hands that are sticking out of the virus that are trying to grab onto your cells and pull themselves into your cells. And if they do that successfully, then it can turn your own cells into little virus-producing factories. So what we would like to do with vaccines is to train your immune system to hopefully fight the virus so they can never do that. Okay? All right, the way that we're going to do that is by exposing your body to those spike proteins so that then you can train a type of cell in your immune system called a B cell to make antibodies, these little Y-shaped things you see. And those antibodies can bind to and cover up those hands, okay, the spike proteins, so they can never grab onto your cells. Okay? If they can't grab onto your cells, they can never get into the cells, you don't replicate the virus, and you don't get super sick, like we've seen a lot of people get with COVID. So that's one strategy. And then the other strategy is also we want to train another type of cell as well called a T cell. A T cell it's another immune cell. And what it does is it can find cells in your body that have already been infected and take care of them so that they don't continue to be these vaccine factories. All right. So again, to kind of look at it, the strategy that's going to be used in these vaccines is that there is going to be a little short sequence of mRNA. And that sequence of mRNA is actually going to code for the viral spike protein. Again, that hand that can grab onto your cells. Okay? It's not going to have the whole viral genome included. There's no way for you to get the virus from this vaccine. It's only going to have the instructions to make one protein, so they can teach your body how to recognize that one protein. Now, that mRNA sequence, if you look at in the top left-hand corner, you can see that's surrounded by this blue circle. That blue circle represents a lipid droplet or a little fatty droplet. Okay? Those fats, the lipids, are just going to it's going to do two things. It's going to provide protection for the mRNA while it's traveling, and then it's going to enable it to fuse to some of the cells in your body, namely muscle cells in your shoulder, so that the mRNA can get into your cells. So if you go from 1 to 2, then you can see that we can give an injection. Those little droplets of fat that contain the mRNA will get into some of your muscle cells in your shoulder. And then just like we saw on the previous slide, now your own cells can use that mRNA instruction to start to make protein. Here it's going to be actually the viral spike protein. And so a few of the muscle cells in your arm then are going to actually have some of these viral spike proteins on its surface. And your immune system is going to say, wait, no, that's not good. That's not supposed to be there. Let's figure out a way to deal with it. And so over time, over the course of the next couple of weeks, it's going to train the immune system to teach T cells and B cells how to fight off those spike proteins, so that if it ever comes in encounter with it, it can start to neutralize it. All right. So if you look at this little animation here, you can see a B cell, a memory B cell that's been trained to recognize the viral spike protein is producing antibodies that can now go and bind to a COVID viral particle and neutralize that particle so that it can't infect cells. Or alternatively, if some of your cells have already been infected, we can also train T cells to go and find those cells and take care of them so that they can't produce any more virus. All right. Now, these vaccines, I want you to make sure that you've seen the list of ingredients, because the list of ingredients can look scary if you don't know what you're looking at. I'm not going to read all these words, because even though I'm a scientist, I stumble over some of these words because they're very long. There's a lot of syllables involved. Okay? But I'm going to tell you instead what they are. Okay? A lot of times in science, we use complicated sounding words to describe relatively simple things. I think a good example is you could say dihydrogen monoxide to just mean water, right? We all know what water is, but if I say I'm going to consume a liter of dihydrogen monoxide, all I'm saying is I'm going to drink a bottle of water. But it's just a scientific way of expressing that in very specific terms. So what you see in these three columns are, the second column is all of the ingredients that are found in the Pfizer-BioNTech COVID-19 vaccine. In the third column, we've got the ingredients for the Moderna COVID-19 vaccine. And the ingredients are almost exactly the same on both of these vaccines. On the very top line, all that we see is where you see nucleoside modified mRNA encoding the viral spike S glycoprotein of SARS-CoV-2. All that's saying is that it has that little mRNA sequence that's going to code for the spike protein. Okay. If we go down and look at the next four things, where you see the polyethylene glycol, and then you see the phosphocholine, and then the cholesterol, and et cetera, all these are just the lipids that are in that little fatty droplet, okay, that are helping to protect the mRNA and allow it to fuse to your cells so that you can actually deliver the mRNA into your cells. So again, it's just very, very fancy words for fats. Okay. I know that a lot of you are probably already familiar with the idea that the Pfizer-BioNTech vaccine has to be kept at super, super cold temperatures, versus the Moderna one also has to be kept at very cold temperatures, but not quite as cold. The reason for that is just because there's different fats in these little droplets that are surrounding the mRNA. I think maybe a good example that you can relate to is if you look at two fats that are maybe found in your kitchen. So Crisco versus olive oil, right? They've got different freezing points. The Crisco is a solid, it's frozen at room temperature, versus the olive oil is going to be liquid at room temperature. You would have to drop it to a much colder temperature to get it to actually form a solid. Right, so that's the only reason why there's these different storage temperatures for these two different vaccines. It's just because you have to get them very, very, very cold for this specific combination of fats that are involved. Okay, and then at the very bottom, the last 5 lines, where you see the potassium chloride and the monobasic potassium phosphate and the sodium chloride and the sucrose and the dibasic sodium phosphate dihydrate. These are just salts and sugars that are going to act as buffers. A buffer is just something that moderates the pH of a solution. Okay, so if you stick something into your cells, you don't want it to be more acidic or less acidic than your cells. You want to have just the right pH. Okay? And that's what these things are doing, is it's making sure that you have just the right pH so that we don't hurt your cells. Okay. And then sucrose, you're already familiar with table sugar. Sodium chloride, again, that's just salt. You want to have the same salt and sugar levels as what you would see in your normal cells. All right. So it looks complicated, but it's not nearly as complicated as it looks when you just read that list. Okay, now I want to spend some time too talking about the actual trials that were done. Okay. So I'll walk through them. We can revisit them later if we need to, but I want to make sure that you've got an idea of how these vaccines were actually developed. Because one thing that's concerning to a lot of people is that the vaccines were developed quite quickly, whereas in the past, usually it would take quite a few years to develop a vaccine. The reason for that quickness is there's kind of two big reasons behind it. One is because of the type of technology that was used. Okay, so for the mRNA technology, again, if you make a new mRNA vaccine, all that you have to do essentially is just change the little mRNA sequence inside of it. Now, if you go back years past, that would have been a very, very difficult thing to do, because if you go back just 20 years ago and you wanted to find out what the DNA sequence of a virus was, it would have taken months and months to years just to sequence that, because it had to be done by hand. Okay? Every single DNA nucleoside that's found would have to individually be solved by hand. Now we can automate that with machines. And so if you are able to isolate a viral particle, you can figure out what the genome of that virus is within a couple of hours. And that was done, actually. So within, by about January 6th, we knew what the viral genome was for this virus. And so at that point, it's extremely trivial to figure out what the RNA sequence is that you would need to stick into a vaccine. So within essentially 2 days of figuring out what the DNA sequence of a virus is, you can make you can figure out what you need to make a vaccine. Okay. At that point, ever since then, it's all been tests that have been being run. So they started off by doing some tests in animals, okay, to make sure it was safe in animals, and then after that, they moved on to phase 1 clinical trials, and the purpose of phase 1 clinical trials is just to look at dosing, to figure out what the best dose is to both be safe and to start to mount an antibody response. Okay? And that's typically just done in a few people. And then phase 2 and phase 3 clinical trials are where you really look to see, does this work? Is it efficacious? And is it safe? And depending on what sort of drug you're looking at, phase 3 clinical trials might include somewhere between a couple hundred people to maybe a couple thousand people. These trials were much, much larger than that. Okay? So you can see here that with the Moderna vaccine trial, there were over 30,000 study participants. And with the Pfizer vaccine trial, there were over 40,000 participants. Let's see, Billy, can you go back? I think my screen went blank.
Sorry about that. 1 second.
It's all right, no problem. There we go.
Yeah, better?
Yep.
Thanks.
So with the Pfizer vaccine trial, we had over 43,000 participants. Again, huge, huge numbers. And what they're essentially doing in these phase 2 and phase 3 clinical trials is they're going to divide the cohort of study participants into 2 groups, one of which receives the vaccine, the other group receives a placebo, okay, little imaginary vaccine. And they don't know if they've received the vaccine or not, but then we watch them over a long period of time. I'm saying we, even though I wasn't involved in creating, we meaning the scientific community. I was not involved in creating these vaccines. But we watch them over a long period of time to see, do they get infected? Okay, are they able to get sick with the virus? And is it safe? What sort of side effects are these patients who receive the vaccine versus receiving the placebo actually showing? And in both of these trials, their outcomes were measured in who got sick. Okay? They didn't necessarily look to see, are people getting asymptomatic infections? Okay? Instead, what their primary outcome was how many people actually got sick in this big cohort of patients. And so if we look first at the Moderna vaccine, okay, what you see in the gold or orange here on the bottom, these are the patients who actually received the vaccine. And this purple line represents the patients who received the placebo. And as you move from left to right on your screen, that's saying how many days since the first vaccine. Each of these arrows, the first one represents the day that they received the first vaccine. And that second little arrow you see, black arrow, that's pointing down the purple line, that's representing the second vaccine that they received. Okay. And every time you see a little tick going up, this is called a Kaplan-Meier curve. And every time you see it go up vertically, that's representing another patient getting sick with COVID. Okay. And they're actually showing symptoms of a COVID infection. So what you can see here is over time, okay, for the group of patients, the 15,000 some odd patients who receive the vaccine, the number who actually gets sick remains very, very low. Okay, this line is horizontal, versus with the placebo group, as you go out in time, that number of people that get sick with the placebo keeps going up, keeps going up, keeps going up, keeps going up. As more and more people get exposed to the virus, they keep getting sick. So this is very, very encouraging results for when you actually look at the efficacy of the vaccine. In fact, if you look at the actual numbers, okay, out of these 30,000 people that were in the trial, for the placebo group, okay, these 14,000 people in the placebo group, 185 got sick, versus only 11 people got sick in the vaccinated group. And out of those who did get sick, in the placebo group, 30 of them had a severe infection. This is where we're talking about having to get admitted to the hospital, oftentimes going on a respirator, et cetera. Okay. Versus in the group that actually received the vaccine, none of them got very, very, very sick from COVID. All of them were protected. None of them had to go to the hospital. For those 11 that did get sick, they only had mild courses of the disease. So when we talk about the 95% efficacy, okay, or here it's 94% efficacy, this is what we're talking about. We're talking about protection against symptomatic COVID, actually getting sick from the disease. Again, we're not necessarily saying that you can't get infected. What we're saying is that if you, regardless of whether or not you're infected, you're much, much less likely to get sick. Okay. Over here on the right side we're looking at the Pfizer vaccine. And this study was even bigger. Okay. Again, 43,000 participants, but you see a similar thing. The placebo group, which is here in blue, as you watch them over time, more and more and more people keep getting sick. Versus in red, this is the people who received the Pfizer vaccine. That number stays very, very low. Okay. And over time, almost the exact same percentage of people are protected in the Pfizer vaccine trial versus the Moderna vaccine. Okay, so there's 95% vaccine efficacy. Okay. And here again, you see that there were 2 doses of the vaccine that were received. One thing I want to point out, though, that's pretty interesting, that's worth noting about these diseases, is if you look at the box that's inserted kind of up towards the top of the graph, this is zooming in on the first 3 weeks. Okay. And if you look at the blue line versus the red line, you can see that for the first 2 weeks, these are the number of days out from receiving the first vaccine, the rate of infection is almost exactly the same. Okay, the rate of actually getting sick from COVID is almost exactly the same whether or not you get vaccinated. Okay. And then it's only later on that you start to see protection. And once you start to get 3 or 4 or 5 weeks out from the first dose, that's when you start to get more and more protection from getting sick from COVID. Okay? That's because it takes a lot of time to train your immune system to actually fight off the virus. Okay? It takes time. You don't magically start producing antibodies and T cells that can fight COVID on the day after you get the vaccine. It takes weeks and weeks. Okay. So you don't actually have really a good, strong protection against COVID until about the kind of safe place is about 2 weeks after the second dose of vaccine is given. Also, if they looked at the amount of antibodies and the T cell response after the first dose versus the second dose. And after the first dose, you start to produce antibodies, but it's only after the second dose that antibody levels really ramp up really high, giving you much more protection. And also, it's not until the second dose that your body starts to produce a T cell response, which is that other arm of the immune system fighting off the vaccine. Okay. So the results are very, very encouraging. Now, that said, I think that the number 95% efficacy also is just a little bit misleading because it sounds fantastic. Okay? However, that also means that if you do the math, that means that 1 in 20 people who receive both doses of the vaccine can still get sick. Okay, so there are going to be still a lot of people out there who do get both doses of the vaccine who can get sick. And the reason for that is just that everybody's immune system is a little bit different. Some people, the first time they're exposed to what we call an antigen, okay, something foreign or nasty, they get lucky with the lottery and they're able to mount a good immune response the first time. They can produce those good antibodies and T cells. For other people, they might have to be exposed to it multiple times before their immune system can learn well. It's just like having a class full of second graders and trying to teach them long division. Some of them might pick it up on the first day. Others, it might take a while longer. Okay? And it turns out that different groups in the community are going to have different levels of immune responses. So typically elderly people have a bit of a more suppressed immune system. So it can take longer and sometimes maybe more repeated exposures before they're able to mount a good immune response. All right. Now Joyce is going to, Dr. Kim will talk about some of the reactions that you actually see in the patients who received both of these vaccines.
Thanks, Peter. I always feel like I learn so much from you. So yeah, I wanted to talk a little bit about what to expect if you do get the vaccine. What reactions will the vaccine cause? So both the Pfizer and Moderna have about equal rates of local reactions. That's specifically redness and swelling, pain to the arm. Both have about 85%. Chances of that happening. If you know anyone that's had the vaccine or really any vaccine, your arm, might hurt for a little bit. Typically that sets in, day 1 to 3 and then resolves within the next 2 to 3 days as well. So that's the sort of lowest totem pole of reaction. And then we move on to systemic reaction. So what sort of things can happen to the whole of my body if I get the vaccine? Both the Pfizer and Moderna look like they have similar rates of fatigue and headache, and they're the majority of patients, greater than 60% for fatigue and anywhere from 55 to 60 for headache. And then as we go down the list, the frequency of symptoms gets less and less, but muscle aches, chills, joint pain, fever, swollen lymph nodes, those are all things that you might see if you do get the vaccine. Interestingly, they did find that the reactions, at least in the Pfizer trial, were more so seen in elderly patients. So the way they categorize older patients were greater than 55, and the younger group was categorized as 15 to 55, which 16, I'm sorry, to 55. And that might not be how I see older, but that's how they defined it. And so for patients between 16 and 55 who received the Pfizer, they actually had a little bit of a increased risk for things like fatigue, headache, muscle aches, chills, joint pain. And those who are older than 55 had a lower risk for those things. And the idea behind that is that it might be that the younger patients are developing more of a robust immune response to the vaccine itself. So these reactions are not bad. Headaches and fatigue are not bad. It's actually showing us that our body is responding well, that the mRNA has been translated into spike protein, and that our bodies are starting to build up antibodies to the spike protein. And a byproduct of that is that we might not feel so good. So the rates, it looks like, are pretty similar for the top three, and then tend to be a little bit higher, it looks like, for Moderna than for Pfizer, for some of the muscle aches and chills, joint pain, fever, swollen lymph nodes. The next slide talks about what are some of the serious adverse events. So I just want to clarify, I think this is where there might be a little bit of fear related to the vaccine, which is totally understandable. Serious adverse events are events that occur within the time frame of the study. So we know that they looked at patients for at least 2 months, if not more. But these serious adverse events may or may not be related to the vaccine. But the companies are required to publish everything that ever happens to any patient that's enrolled. So that's a lot of people. Thankfully, it looks like there's only 2 related serious adverse events that Pfizer reported. The first is lymph node swelling. This is actually not lymph node swelling that we had discussed in the previous slide. What made it serious was that it was actually in the arm that was not vaccinated, and so probably required further workup. And then shoulder injury, presumably to the arm that was given the vaccine. And then the unrelated serious adverse events, the list for both of these trials actually is pages and pages long. So I just included a handful of them sort of to show what the logic is behind looking at these and studying them, how they're reported. And also to point out that all of the remainder of the unrelated serious adverse events occurred in less than 1% of the people that were studied. So very, 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 very rare. So under Pfizer, you'll see appendicitis. There were 8 cases of appendicitis in the vaccinated group versus 4 in the placebo group. So does that mean that the vaccine caused appendicitis? It doubled the rate. What we have to think about is that you always have to consider what the baseline incidence of appendicitis is in the general population that was studied. So we know, just from knowing appendicitis, that for patients who are 16 to older than 55, there are differing rates, but a conservative estimate would be 0.2% of the population develops appendicitis. And so if we look of the people who were studied, 8 out of the safety data was reported for about 18,000 patients. It's a lot less than 0.2%. It's 0.04% actually. And so there's no way to say that the vaccine caused appendicitis, because it's actually less than what you would expect for just the general population. If you took 18,000 people who neither had vaccine or placebo, more would have had appendicitis. Just like if you move down the list, syncope is that last one in the unrelated column. There were 4 cases of syncope, which is a fancy name for loss of consciousness or passing out. 4 cases in the placebo group and 1 in the vaccinated group. We would not say that having received placebo made you at an increased risk for passing out. So all of these cases, again, were less than 1%. Some were more in the vaccinated, some in the placebo, and feel free to look at that slide, but I just included some of those numbers, but none of them were found to be related to the vaccine itself. The last row highlights death. So can we die from these vaccines? That's a pretty scary question that they answered for us, actually. So there were 2 deaths in the vaccinated group and 4 deaths in the placebo arm for Pfizer. Just to give a little bit of background about this, both that were vaccinated were greater than 55, one had a history of arteriosclerosis, which just means arteries that are blocked, and baseline obesity, and the other passed from sudden cardiac arrest. In the placebo group, 2 were also greater than 55. One had a stroke, and the other had a heart attack, and 2 were in the younger placebo group, 16 to 55, those of whom the cause of death was unknown. If we move over to the Moderna column, there were 6 who passed, who did receive the vaccine, and 7 who passed who did not receive the vaccine. So fairly equal there. And they also had similar causes of death: cardiorespiratory arrest, heart attack, and other cases that did not actually have anything to do with whether or not they received the vaccine or the placebo.
One thing to add there is that if you look at other, just as a baseline, if you look at other vaccines in the past, anytime that they've recorded long-term side effects from the vaccines, those long-term side effects have typically popped up within 15 to 30 days after you receive the vaccine. And so for that reason, they made sure that before reporting any of these numbers, that they had watched everyone for at least 2 to 3 months. And they're still continuing to watch those people now. And if you, again, these are very, very large numbers included in these studies. So if you were lucky enough to have 75,000 friends, then you're going to see over the next 3 months, a few of those friends are going to die from random causes, or they're going to get sick, they're going to get pneumonia, some of them are going to pass out, et cetera. And that's not necessarily because they're your friends that happens.
Yeah, that's so true. Thanks, Peter. The polio vaccine, when it came out, they knew that it could cause polio. 1 in about 2.5 million doses given might cause polio. We know Guillain-Barré is a paralysis event that can happen sometimes after you get the influenza vaccine. That's 1 in a million cases. So very, very rare, but they did know about it before within that time frame that Peter was mentioning, within those 2 months. And so that was the question, is it safe? Is 2 months enough? And the virologists and immunologists that had thought about all of the other vaccines in the past and really serious adverse events that we had seen with them, they occurred within those first 2 months. So it made it more robust to think about it that way. All right. Billy, can we go to the next slide, please? Thanks. So who should not get the vaccine? One answer is anyone who's allergic to it. So how do you know you're allergic to it? You might not know until you get the first dose. So if you do, don't get the second dose. But also, if you think about the components of the vaccine, we think that the allergic reactions are coming from one of the fat portions that Peter had mentioned, called polyethylene glycol. You might be familiar with that PEG. It's also called Miralax as a laxative. It's included in a lot of topical and cosmetic agents. And so if you're allergic to it, you probably at this point know I don't think you could have avoided it your whole life up until now. So if you have a history of severe allergic reactions to polyethylene glycol, then you should not get the vaccine. Polysorbate is a relative of polyethylene glycol, and so it's the same issue there. The other 2 caveats is if you've received monoclonal antibody treatment within the past 90 days, you should not get the vaccine. And that's not because you're going to be allergic to it or anything like that, but if you've received synthetic antibody, some of the a common name you might have heard is Regeneron. I think President Trump received Regeneron. So he would have to wait 90 days from the time that he received that to receive antibody treatment, because you're essentially going to that monoclonal antibody that you've been given is going to respond to the spike protein and not let your body mount its own response. It's going to do all the work for you, and you won't be able to develop protection against it. And the same idea applies if you're currently ill with COVID, or if you're in quarantine because you've had a positive exposure, and the assumption is that you do have it as well. We want your body to mount a good immune response to the vaccine, and so those are two caveats for why you might want to wait. So you can get the vaccine, but wait until you feel better from having had the virus, or at least 90 days after you've received treatment. Some of the other groups that we think about in terms of these vaccines that the trials did, some were addressed and some were not, just the way that the trials were designed, are persons with autoimmune conditions. So the trials weren't closed to anybody with an autoimmune condition. You think about, rheumatoid arthritis or lupus, Crohn's disease, ulcerative colitis. They weren't closed to them, but they didn't actually come out with a lot of safety data for patients who have autoimmune conditions. So if you remember, an autoimmune disease is when your immune system actually works really, really well. It works a little too well, and it thinks that your own body is foreign, and it starts attacking its own body. And so in order to circumvent the response from that, some people with autoimmune conditions are placed on immunosuppressants. They suppress their immune system so that they can suppress the symptoms of the autoimmune condition. So that would mean that you might be at risk for more severe symptoms if you do get the virus, but also it might mean that you might not build up a good enough antibody response once you get the vaccine. So it's definitely a conversation worth having. It doesn't mean, you can't get the vaccine, but, will you develop a good enough response? That's a very good question. And again, we're presenting information here, not trying to give blanket medical recommendations. And it is a really good conversation to have with your doctor. That being said, the CDC does recommend that all persons with autoimmune conditions that don't have any other contraindication, like allergy to polyethylene glycol, ought to get the vaccine. The elderly, we touched on this, but persons older than 65 were included in the study, and there weren't any differences in efficacy or safety that they were able to find between the two groups. And so it's definitely recommended for all age groups 16 and above. For pregnant persons, the CDC and the American College of Gynecology and the Society for Maternal Fetal Medicine are all recommending that pregnant persons not be excluded from getting the vaccine. So it's not a firm, yes, get it, but if you desire it, then you should not be excluded from being able to receive it. Interestingly, I think the UK is a little bit more cautious about their recommendations, but also say essentially, if you're in a high risk position to get COVID, that you ought to think about getting it and have a conversation with your doctor. Lactating persons, there's no data for this yet. It's not thought to be a risk to their breastfeeding infant. The transmission of COVID through breast milk doesn't seem to occur, and so there's no reason to think that the vaccine is going to cause any issues. If we think about it, we actually promote breastfeeding in a lot of mothers because of something called passive immunity, where they can actually give antibodies that the infant hasn't actually had to work for, so that the infant can then be protected against various pathogens. And perhaps this is the case. We're not sure, but that might be actually something good that comes of that. The immunocompromised. So there were patients with HIV that were included in both trials. The patients with HIV were controlled, and I'm sorry, so their HIV was under control, and they were taking their medications, but there wasn't a lot of data from this group either. But again, the CDC is recommending that anyone who does have an immunocompromised condition receive the vaccine if they don't have any other contraindications for it. Children less than 16 were not included in the studies. I think those studies are starting soon, but those children as well are actually not recommended to have the vaccine. So I hope that wasn't too dense. I hope I wasn't talking too fast. But yeah, Billy, if you want to go to the, oh, there you go. So that was sort of the formal presentation of this all. And Peter and I wanted to open up the floor for question and answers. We know that there's a lot of questions out there, and we hope that we can do our best to provide solid information for you. So.
Absolutely. Joyce, thank you. Peter, thank you so much. We're going to get right to these questions. Just a quick little note on housekeeping. We asked for questions in advance, and so we got a list of those we're going to go through first. As questions come up for you, just put them in the chat. And we will discuss these for as long as Joyce and Peter are willing to go. I think we set a time for 3:30. So if you can stick around till then, everybody, please do. We may need to reschedule one of these and do some more of this stuff, which would be a joy to do. So, yeah, so let's get started. So here's a good one. Do I have to wear a mask after I'm vaccinated?
You want me to take this, Joyce?
Sure, go ahead. Yeah.
So the short-term answer is yes for the short term. Okay. And so there's a few things that are built into this. One is immediately after you get vaccinated, as I mentioned before, for the first couple of weeks, you essentially still have no immunity against the virus. Okay. You can still get infected. You can still get sick. Okay. Now that said, if you look a little bit longer term, so let's talk about maybe 2 or 3 weeks after you get the second vaccine, that's a little bit of a different story. And what we're going to say here, the recommendation is, at least for right now, while there's still a lot of virus that's being passed out in the community, you should still wear a mask. And the reason for that is, even though as a vaccinated individual, you are very unlikely to get sick, you could still get an asymptomatic infection and pass it on to other people. Okay, so you can still be a vector passing it on to other people. And the reason behind that is scientifically a little bit complicated. I don't want to get too much into the weeds and make people fall asleep, but your body has different types of antibodies for different things. Okay, so if you look at the main type of antibody that goes through your bloodstream, it's called IgG. Okay. And when you get the vaccine, you make a wonderful IgG response, especially after the second dose of the vaccine. If you look at, though, at a lot of the cells that actually first get exposed to the virus, those are going to be cells in along your respiratory tract, in your lungs, et cetera. And some of the antibodies that can prevent you from getting infected and kind of get that local infection are going to be IgA antibodies. And we don't know yet if the vaccine is going to do a good job of producing an IgA response. So you might essentially be able to get just a small local infection that you never notice from the virus, just enough to get it and pass it on to other people without actually getting sick with it yourself. We do know from, again, some preliminary data that after getting 2 vaccines, you can still get asymptomatic infections. That said, if you look at that number of people, the amount of virus that you have in you is way lower typically than someone else that gets infected, which means it's harder to pass on. If you are an asymptomatic carrier, it's probably less likely that you could pass it on to other people, but it's still possible. Does that maybe answer the question?
Yes.
So once enough people are vaccinated and there's not as much virus out there, Okay, then eventually we can start to hopefully decrease the mask wearing because again, someone who's vaccinated, if they do get infected, they can't have as much virus in them. Okay, so they're not as likely to spread it, and there just won't be as much virus around.
How many is enough? How many is enough people?
Oh, that is a great question.
Thank you.
That is a great question that we don't fully know the answer to yet. Current estimates are somewhere between 70 to 80% of the population would need to be vaccinated, but we don't fully know the answer to that. And the reason we don't fully know the answer to that is because the answer could change depending on emerging variants. So we don't fully know yet because of that.
Okay. So that's a great segue. There's a question here about the variants. Are the current vaccines effective against the variants we're seeing?
Yes, is the short answer. But again, things get more complicated. So if the variants that we're kind of most concerned of right now is one is the UK variant. These have better scientific names, but the variant that was first discovered in the UK, that one's a very, very quickly traveling variant that is already found here in the United States, and it's got a lot of people worried. That said, current studies are looking wonderful that the vaccine should do a great job of neutralizing it. Okay, for the South African variants, that one's not spreading as widely in the United States right now. But if we look at how the antibodies from the vaccine are able to neutralize it, yes, they can still neutralize it, but they don't do it as good of a job as they do against the original virus. Okay, so there's a great chance that if you want to kind of hedge your bets, it's still going to work, but the efficacy number might drop down from 95 to some lower number. And we won't know what that lower number is until there's a full new set of clinical trials or epidemiological studies that have been done to look at actually how many people who have been vaccinated get infected with the South African variant. Additionally, there are new clinical trials that are currently underway to see if an additional booster dose will provide additional protection against the South African variant. And there's also, Moderna is already working on a new vaccine already that is specific to the South African variant. Again, that's one of the beautiful things about the mRNA technology is it's really quick to just swap out one mRNA sequence for another. And so they're already starting to work on clinical trials, just in case we eventually see that variant escapes our current immunity. We can hopefully quickly produce another vaccine that will work.
Okay. Thank you. Thank you. So let's talk about access to the vaccine today. Dr. Hiltz, are you still with us? And Daryl?
Yes.
Hey, I got a question for you. Where and when can I get a vaccination is a question we have.
Okay, I can take that question and Daryl can add to it if I miss anything. There are several providers in our community that are offering the vaccine, and we have a link on our website, and it's also on the State Department of Public Health website as to who those providers are. And of course, that's constantly changing, so I recommend checking that often to see. Right now, we know Publix, Sam's, our hospital providers, those providers are coming on board slowly. But just speaking from the public health perspective, we have vaccine available and we're getting it in very small quantities compared to how many people have pre-registered to receive it from us. Just to give you an example and some context, we have for Columbus alone, about 20,000 people who have pre-registered on our website who say that they want to receive the vaccine from us at Public Health. But we've only received about 1,300 doses of vaccines, approximately. So we are going to work through the list of people who have requested it from us, but we can only get to those people as vaccine becomes available. And it's in very limited quantities right now. We're hoping that will change in the future and we'll get more vaccine, but as soon as we get it, we're getting it out to the community. And as you know, right now we're in phase 1A+, which are medical providers, our laboratory workers, law enforcement, emergency responders, and our 65+ community members and their caregivers. So that's where we are right now.
Awesome. Thank you. Thank you. Asante, a follow-up. First of all, thank y'all for what you're doing. This is a huge lift, and y'all are doing a great job. We're thankful to partner with you guys, and thanks for joining the call. This is a related question. I live in Alabama and work in Georgia. Can I get a vaccination in Georgia?
Yes, if you work in Georgia in a healthcare setting or law enforcement, everything that I just listed for phase 1A, you have to work in one of those categories.
Yeah. And one last question, and then you can jump in as you guys feel like you'd like to, Asante. Will there be opportunity to get the second vaccine if you get the first vaccine? I guess the booster versus the first shot.
Will there be an opportunity to get it? That's the question.
Yeah, so both rounds of the same vaccine. Is there enough supply for you to get the second shot, however many days later, 28 days later?
And again, I can only speak from the perspective of public health. We will be administering the second dose for anybody who we give the first dose to.
Okay. Awesome. All right. Great. Thank you. So Peter, back to you. How soon after the vaccine's administered will someone be protected?
You should expect to get good. So you're going to start to see protection, some level of protection about 3 weeks after the first vaccine, but it's not going to be a really full and robust protection until about 2 weeks after the second dose.
And should I get the vaccine if I'm at low risk for COVID complications? And if so, why?
I would say absolutely yes. And the reason for that is because even though you might think that you're unlikely to get sick, you can still pass it on to someone else. Now, if you're okay with passing it on to grandma and her dying from you passing it on to her, I don't know how to speak to that, but I personally would have some grave issues with that. Additionally, young people who think that they're not going to get sick from it aren't necessarily quite as protected as they think they are. There have been a lot of papers that have come out over the past couple of months taking a look at athletes, and they've seen that athletes who get infected with COVID and they've got mild symptoms, months later can present with inflammation of their heart that can actually lead to deadly consequences. And that happens in about 1.4% of healthy young athletes who are like, and the people who you would think would be the most healthy people in the whole country are at a risk of having serious long-term side effects from a mild infection of it. So even if you think that you're unlikely to get sick, yeah, you should still get it. Also, if you've previously had a COVID infection, we've seen lots and lots of people who have been reinfected with COVID. Okay? So just because you've been infected once doesn't necessarily mean that your body has fully learned how to make those antibodies and protect itself. Just like how you need more than one dose of the vaccine to produce a good antibody response, it's similar to how sometimes one infection is not enough to give your body time to learn how to fight off the virus.
And I think you touched on this earlier. There's another question kind of about, maybe if you could just reiterate this, because this looks like a popular question about the transmission. It says, is there any data that's ready to suggest the vaccine limits transmission of COVID? Even data given how other vaccines work. So I guess compared to other vaccines, or what's the, again, if you could go back to that point about transmission of COVID after receiving the vaccine.
So the answer is yes, again. So even though we know that people who get vaccinated can have asymptomatic infections, and if you're an asymptomatic person, that's how most of the spread in this country is happening, is through asymptomatic and pre-symptomatic spread. So people who get vaccinated can still be asymptomatic carriers. That said, some studies have shown that the rate of asymptomatic infection is about 66% less in individuals who receive the second dose versus placebo. Okay? So it definitely can reduce the chances of you being one of those asymptomatic carriers, which means it reduces the risk of spread.
Cool.
Yeah, I just wanted to add that there are estimates for how often asymptomatic transmission occurs. It's difficult because you're asymptomatic, and so, Sometimes you can't catch it. But anywhere from 25 to 50% of the cases of COVID are from asymptomatic transmission. So there's not firm data that says these vaccines can prevent asymptomatic transmission, but there's firm data that it does prevent serious COVID and even mild to moderate COVID. And the other, 50% of the population that's diagnosed with COVID are receiving it from sick individuals. And so, yes, it will decrease transmission if we have, the vaccine readily available and used.
Does the vaccine alter my DNA?
No, there's no way for it to alter your DNA whatsoever. It's just a scientific impossibility. So if you remember back to that one of those first slides when I was walking through kind of the order, we call this the central dogma of molecular biology, is you go from DNA to RNA to protein. Okay, and your body has no mechanism to go from RNA back to DNA. And there's no way for that to happen. Also, when you look at the direction that the mRNA travels, it's able to travel from inside the nucleus out into the cytosol. Okay, there's not a mechanism in place for it to be trafficked in the other direction to go back into the nucleus. So there's absolutely no risk of it altering your DNA whatsoever.
Okay. And how long will the mRNA persist in my body?
Only for mRNA itself is a very unstable molecule. There's enzymes all over your body and actually all in nature that break down mRNA very quickly. Also, DNA is stable because it makes this nice double helix structure. mRNA is single-stranded. Again, that makes it more unstable. So mRNA in your cells can only last for a few hours. Up to the max recorded is typically about 24 hours. So you're sticking it in there, it does its job, and then it's gone very quickly.
And is there any risk of getting the virus from the vaccine itself?
Zero risk. It's an impossibility. If you receive the vaccine and you come down with the virus 2 days later, that means that you've already been infected with the virus. Okay? It has nothing to do with the vaccination.
Got it.
If you think about the way the Pfizer mRNA has to be transported, it's a reflection of how unstable the mRNA is. In laboratories where they work with mRNA, they have these -70 and 90-degree freezers because it's the only way you can handle it. And so it degrades very rapidly.
Okay.
So, yep, and same with in the body.
Awesome. How am I doing asking questions, guys? Am I doing okay?
Reaching up.
So let's see. This question's about this. I guess this is an opinion question. What can be said to those who don't want to get the vaccine in order to encourage them to do so?
I think empathy goes a really long way. I heard a virologist speaking about this, and he says, "Am I a vaccine skeptic?" Yes, I am. And I was really surprised by his answer. But he substantiates it by differentiating sort of a cynic versus a skeptic. A cynic says, no matter what data is presented to me, I know that all vaccines are bad and, might cause autism. So no vaccines for me, period. And there's not a lot of conversation that can be had when you're facing cynicism. But skeptics, I think, are waiting for data. Show me the data. What does it actually show in a person my age, a person my race, a person with my background, with my medical comorbidities? Does it work? And so I think we're entrusted to present that data to say it really is effective. I've had 3 patients today who felt vaccine hesitant for the COVID vaccine, and they were all elderly. And I really, thankfully, they were open to the conversation. So I was able to present that sort of information, that it's effective, especially for you. You have diabetes, you're older than 65. We know that the risk of death in patients older than 80 is so high, or severe COVID at least, and then death is much, much higher than if you were in your 40s even. And so just presenting the the benefits, I suppose, and the realistic risks, like we try to do in the presentation. What side effects can you expect, and what are some of the scary ones that aren't related to the vaccine at all? Yeah, so providing that information, I think, is probably the first step. So.
Okay. Would you say the vaccine is safe? This is a simple question here. It says, "Is it safe?" Question mark. Is it safe?
That is such a good question. I think that's probably the lingering thought. And it's one that I've thought about a lot because I think it's such a good question, because the answer is based on how we define safe. If we're saying safe means 100% risk-free, there is essentially nothing in this world that is 100% risk-free. And so it changed sort of my mentality, about even providing medical care. And if the question is, do we know enough, or how much information do we need to know enough? I think that's a better question than is it safe? How do we determine safety? When is the number of people studied enough? And I suppose our stance, our argument during this whole thing is that it has been studied in enough individuals to say that it is safe. In the population that was studied, so that we can say assuredly that it is. We know that it's more than 95% effective. We know that 30 people were diagnosed with severe COVID, hospitalized, who were not vaccinated versus 0 who were vaccinated. That evidence is so strong, and we know that there weren't serious adverse events that were related to the vaccines that lead to anything like hospitalization or death. So I would say it's safe, and also just to think about how we define safety. Okay. I don't know if you had anything to add, Peter.
I completely agree with that. I think that defining safe is an important thing too. Like if someone asked most of us, are almonds safe? Then we would say, yeah, almonds are safe. But that said, there's some people who have almond allergies. So in general, it's typically very safe, but there are going to be, just some very rare instances where people might have bad reactions. Same thing we think about Tylenol as being safe, but if you take too much Tylenol, it can lead to liver failure. We think about aspirin as being safe, but too much aspirin can lead to stomach bleeding. Lots of things. But again, they're typically safe, and I would say the same thing for this virus. I think the studies were done very well. I was a skeptic all the way through the studies until I actually got to, because I'm a skeptical person, until I actually got to look at the data and the efficacy myself and see what the side effects were, see how they ran the trials. And it's passed muster for me. So I think that it's safe. I've been encouraging my own family members to get it, and I encourage them out of it's a motivation of love to get it, because I do think it's safe, and I think that it'll protect them.
Okay. Related question, I think it's they're 94% efficacy rate. How does that compare to, how does that compare to other vaccines that are commonplace today?
Well, we know. Is that me?
Wow, it's a nice sound effect.
I think Kenneth Falwell needs to.
I got it. All right, Joyce, go ahead.
Oh, wow. Master switch over there. Awesome.
Go ahead.
So, the question slipped my mind. Sorry, one more time.
So we're at 95%,
That's right.
94% efficacy. Talk about how that compares to other vaccines that are common.
Mm-hmm. The most common one that we probably see and have every year is the flu vaccine. And that has a much lower efficacy. Some say as low as 25%, some say 50, some say 75. So it's sort of all across the board. Even if you take the highest estimate, 75%. the flu vaccine is not that effective. It's because it does mutate every year, and so it's difficult to nail down with the vaccines that we have. So comparatively speaking, to be able to say that a vaccine is 94% effective is actually very rewarding as a medical professional, to have something that solid to say. I think in comparison, I mean, the measles vaccine, very, very effective. I think that's also 99% effective. But again, nothing's 100%. Peter, I don't know if you knew vaccines off the top of your head in terms of efficacy rate.
I don't keep those numbers in my head very much, but one thing I'll mention that the efficacy rate can differ among different populations. So if you, for instance, if you look at one of the reasons why Joyce mentioned that there's different numbers for the flu vaccine is well, one thing is there's a different flu vaccine every year, and some years it's more effective, and other years it's not effective, and also you have multiple strains of it going around. But even within 1 year and one flu vaccine and one strain, if you look at the elderly population versus a younger, healthier population, typically the vaccine works better. That particular vaccine works better in younger populations and gives them more protection than it does elderly populations. So it can be different, and it's hard in different populations, and so sometimes those numbers are hard to tease out. But typically, everyone is. The scientific community was kind of praying for at least 50% accuracy from efficacy from one of these vaccines, and so the effectiveness has kind of blown everybody away.
Good. All right, quick questions here. If you suffered side effects from the first dose, fever, chills, in bed with flu-like symptoms, is it advisable to take the second dose?
Yes, it is. Yes, those side effects are expected. Some tend to have worse side effects than others. The studies look like younger patients will have those symptoms a bit worse, but it's actually a good thing, as horrible as it sounds. When you're feeling ill and in bed, your body is mounting its response. So it's building the militiamen to be able to fight off the virus if and when you do encounter it. And so that would not be a contraindication to get the second dose.
I'm going to try to merge a couple of different questions here into one that are similar. There's one question about reports of constant headaches after taking the vaccine, and then another question about the long-term effects. I know that Peter, earlier you mentioned about how in studies the effects that somebody is followed is for 20 to 40 days. I'm trying to remember. I don't know if I remember that right. But are we concerned about the long-term effects of the vaccine and those impacts of someone that might be immune compromised? So I don't know if it was okay to merge those two questions, but the first one being constant headaches and the other long-term effects of the vaccine.
Okay, thank you. Yeah, typically the headaches from the studies, at least, people will develop headaches within the first 1 to 3 days of having received the vaccine, but they also do dissipate within the next 1 to 3 days of having had the vaccine. I haven't read any studies that particularly say these headaches are long lasting. I don't know if someone is on this call if the writer of the question is on the call, it'd be great to hear a little bit of background about what that question is pointing towards.
Yeah, just put it in the chat if you're on. And then the next question, Joyce and Peter, the long-term effects. I'm going to just read this one. This person's immune compromised, and to this person's knowledge, there's no studies on blood cancer or immune compromised people yet. Should I continue to be careful and wait, or receive the vaccine now? Oncologists are recommending it, but that's because it could play havoc if I were to get it.
Yeah, this is one of those areas where I don't want to give blanket medical advice, because I'm not too familiar with the person's medical condition. I would definitely recommend talking with your doctor. I hope that the portion where we talked about immunocompromised patients was helpful for you. whoever wrote the question, because the CDC does recommend receiving it. It's also fair to say that there isn't any hard and fast data about that other than the HIV patients who are stable and controlled, for whom the data has not yet been released. And so I can't say definitively, but there's, yes, sorry, I'll leave it at that.
Can I add to that just a little bit?
Mhm.
Yep.
So for immunocompromised individuals, if you look at other vaccines that might be given to the populations, typically you don't give live attenuated viral vaccines to immunocompromised people, because that kind of subcategory of vaccine, it can actually, because those people are immunocompromised, it can replicate within them and actually infect them. That's not an issue here at all. That scientifically, again, there's no way to get an infection from this vaccine, which is really encouraging. Joyce is absolutely correct that we don't have a lot of data as far as looking at cohorts of patients who are immunocompromised and seeing how how they'll do with the vaccine. But again, the current guidance is for them to receive it, because hopefully then they can have a better chance of fighting off the COVID vaccine, whereas previously they would have been at one of the most at-risk groups for it. Also, with just a little side note about the headaches, you can take, as long as you've got no other medical reasons preventing it, you can take Tylenol or Advil after you receive the vaccine if you to deal with some of those symptoms. That's not going to affect your body's ability to mount an immune response to it. You should not take Tylenol or Advil or ibuprofen prophylactically. So you shouldn't take it before you receive the vaccine, because there have been some studies in other vaccines where it shows that if you take those things right before you get the vaccine, it can depress your body's ability to make antibodies. But if you take it afterwards when symptoms come on, then that should be fine.
Yeah, I guess devil's advocate, there are some schools of thought that would say if you did take Tylenol, you might decrease your immune response and thereby not develop as many antibodies. And so, so there's some people that are saying, if you can tough it out, then tough it out. And when is it okay to take, something like Tylenol or aspirin, maybe a week after, so that you know that your body's had its fullest chance at developing antibodies. So I guess we're still finding out. There are some schools that would say try to avoid Tylenol even. So
yeah,
we don't know for sure for this vaccine until, again,
yeah.
you have to do a specific clinical trial just looking at that.
And that, you guys, was a debate amongst doctors. Hey, one last question on the questions in advance, and Joyce, I'll ask for a quick answer on this one just to you. What's considered standard treatment should one come down with COVID-19?
Yeah, I'm assuming the person who posed the question is asking about mild, moderate COVID that doesn't require hospitalization. The NIH has a really neat treatment guidelines article, and essentially there's not too many things that are recommended. So what is recommended is conservative treatment. So staying hydrated, resting, letting your body recover, all of those things that we already know. You can, if your fever is getting really high or your headache bad, use Tylenol or aspirin at this point. It sounds like that's been debunked. It used to be, our NSAIDs unsafe in COVID, but you can. Some people anecdotally will say that they feel better if they take vitamins D and C and zinc, which again, there's not a whole lot of data that says that's true, but there's also no data that says those things are harmful. And so when my patients are feeling particularly ill, I'll suggest the vitamins anecdotally, to say I've had a couple other patients who did really well when they use these. And then the treatment obviously differs if you're hospitalized, and there are some trials. There are trials actually for mild to moderate COVID in the outpatient setting that involves monoclonal antibody treatments. We had mentioned that before, like Regeneron, and there's another one, I'm going to butcher the name. It starts with a B. But so those are trials that are going on that you could get enrolled in, especially if you have a lot of underlying health conditions or comorbidities that might make COVID worse for you. And I know there's been a lot of chatter about ivermectin as well. Again, it's just there's not a lot of data. That's why it's nice to say there's so much data behind these vaccines. But ivermectin is, it doesn't look like there have been really, really well done studies quite yet. But the ones that have come out don't seem to convince at least the really smart people that it's effective and would be widely recommended or considered standard of care at this point. So
cool. Do we know about I'm on the chat box now, so Dr. Kim, Dr. Huwe, if you want to follow that along, you can. We're going to go, I think the first question got answered. I think we addressed that about the long-term health impacts. With regard to this next question about the percentage, do we know about the percentage of people of color that were in the trials? And were any adverse effects found along regional or racial lines? The virus affects people of color differently. Does the vaccine have the ability to do the same?
So for the African American population, they were well represented in the studies. There was about 10% in both trials. They sort of hover around 9.8 and 10.2, I think, in both the placebo arms and the vaccinated arms. And if you look at the general population in the States, African Americans make up 12.7% of the population. And the studies were really clear that it did not matter what your race or gender or age or underlying health conditions were. When you received this vaccine, it looked like the efficacy was equal across the board. So I hope that answers that question. Peter, did you have anything else to add for that? Okay. Were any adverse effects found along regional or racial lines? No, I mean, reading the fine print, there really wasn't anything that would indicate that the vaccine reacts more poorly in people of color than not. Okay.
Let's go to Bart's question. Who needs the vaccine the most? Do the elderly and immunocompromised need it the most, or the younger, healthier folks need it the most?
Yes.
There you go. There you go, Bart. We got it. All right, move right.
Everybody that can get the vaccine who's not in one of these very select groups. So as long as you're not infected right now, you haven't received monoclonal antibodies in the last 3 months, and you don't have any allergies to it, then I would encourage most of those groups to get it. Again, though, there are a few groups that, again, we don't have a lot of data on right now. So for instance, if you look at pregnancies, a lot of pregnant individuals are hesitant to get it. And so what I would suggest that because again, we just don't have a lot of data yet. There were a few pregnant people who accidentally were, or didn't realize that they were pregnant, but ended up in the trials, and that stuff ended up well so far. But we just don't have a lot of data so far. So if you happen to be pregnant and you want to know if you should get the vaccine or not, I'd encourage you to speak to your OBGYN. And it could just be that you need to do a risk-benefit analysis. If you're someone who is out there exposed to other people a lot, then you should probably get it. If you're someone who is able to stay at home for 9 months and the people that live with you aren't likely to bring it home either, then you can maybe wait till afterwards. It's a risk-benefit thing that you should talk to your family about, talk to your doctor about, and make those individual decisions. But I'd say most of the population, I would really encourage them to get it. And again, it's out of a place of love, not kind of scientific ivory towerness that I encourage it for.
Yeah,
that came across well, Peter, by the way.
Yes.
We appreciate it.
I agree, always.
That is the place to go. Go ahead, Joy. Sorry.
Yeah, no. The CDC does, as a little caveat, say that if you have had the virus within the past 3 months, and you're young and healthy, that if you wanted to consider waiting, that would be okay. It doesn't seem like you can be reinfected within 3 months of having had the virus. And I only say that because this is definitely my own personal opinion, but because of the shortage, yes, everyone should get vaccinated, but realistically at this point, 20,000 people registered with the health department and 1,300 doses that are available. That's a pretty limited supply, and hopefully that'll change in like the next month, and this won't actually apply. But yeah, if we know that 15% of those over 80 can die from COVID. So the effects seem to be more severe as age increases. And so just food for thought, I guess.
Cool.
One other thing that I'll just kind of add, when you're thinking about different groups getting vaccinated. So if you happen to be in that immunocompromised group, or you happen to be in the autoimmune group, or the pregnancy group, and you plan on getting a vaccine, I would encourage you to check to see if there are clinical trials that are currently going on that you can enroll in. Because Joyce and I keep saying, well, based on the information we know now, based on this information, we either know this or we don't know this. And all of you could really help give us more information so that we have better answers going forward. If you're planning on getting it anyway, then let some people actually record some data so that we've got some better answers later on.
Great, thank you. We're going to go through these next questions pretty quickly. We're almost at 3:30, so we understand folks, y'all been with us for a while, so if you need to bounce, you can. This question comes from Eve Parks. Will MercyMed administer the vaccine? The answer to that is yes. We don't know when, but we will. It is our desire to administer that to our patients as soon as we're ready and as soon as we're able to start. Joyce, do you want to add anything to that, or we don't have them right now, but we're working towards a plan to get that together. Is that accurate, Joyce? Anything to add to that response?
Nope.
Yeah. Teddy Usry requests, does blood type have any bearing on the vaccine?
Not that I'm aware of.
Okay. Is this session recorded for those that can't join? Yes, absolutely it is. We'll post it online later. Teddy Usry asks, if you have a low white count, does it matter? Is it still okay to take the vaccine? And then do we think that the Johnson & Johnson vaccine will have the same results? So 2 questions there. Low white count. Dr. Kim, do you have any info on that?
Yeah, the low white count, that's an interesting question. I will say in the studies, they didn't specifically group out patients with, it's called leukopenia if you have a low white count. But you would fall under the category of immunosuppressed at that point. I do wonder maybe, what those HIV patients, what their white counts were. But because you do fall under immunocompromised, I don't know that there's anything definitive to say other than the CDC does recommend. And there weren't any red flags against getting it. Peter, did you have it? Were you going to say something?
No, I completely agree. It's the one thing we don't know is we don't think that the vaccine will, at this point, it doesn't look like the vaccine will hurt individuals who have low white blood cell counts, but we don't know yet how effective it'll be. So if you have low white blood cell counts, then that might decrease your body's ability to make those antibodies and to generate those T cells. And so we don't know the answer to that yet. Again, the hope behind a lot of these recommendations is that it'll provide some protection better than you have right now, but there's just really a lack of data in that population right now. As far as the J&J vaccine, we don't know the numbers yet on that one. Those numbers, I've heard rumors from people who are conducting the clinical trials that they should be applying for emergency use authorization in the next week or so. And so that's when those numbers of efficacy for their vaccine will come out.
So maybe we can do one of these again. I'm gonna put Peter and Joyce's cell phone number in the chat later, guys. You can text them anything later on. Where on your website can the information about vaccines be found? MercyMed does not have any vaccine information on our website that I know of. This will be the first piece of that. We'll get that out there. I know I don't know if Asante's still on or not. The health department's website has a lot of great information about vaccines, as well as an easy sign up form at the Department of Public Health website. I think it's say again?
westcentralhealthdistrict.com.
westcentralhealthdistrict.com. So I would point you there for most up-to-date information. Thank you, Daryl. Good to see you, man. I wish you'd turn your video on. We can't see you. So yeah, there he is. That's Daryl Infinger, y'all. Bart Scarborough said to me directly, "You're doing so great." Thank you, Bart. Connie Smith, after vaccination, how long does immunity last? I think we touched on that earlier. Did we cover that, Peter?
We didn't fully cover that, and so we don't fully know the answer to that because the trials that were done, they started about a year ago. Well, some of the very earliest ones started about a year ago. So we can't for sure say that it lasts more than a year because we don't have hard data to support that. What we can say is that for the people that were immunized with both of these vaccines, they did, for people who kind of got the early shots, they looked at T cell and B cell responses 6 months later. So the antibody titers, and those numbers still look good 6 months out. So because those numbers haven't decreased yet after 6 months, the assumption is that they should stay strong at least a year out. That said, again, if some new emerging variant of the virus comes through, then maybe your response won't be quite so great to that variant, and maybe later on we might need some new booster shot to that. We don't fully know that yet.
So there's a possibility we could get our COVID shot once a year.
Possibly. That's what a lot of people are thinking, but again, we don't fully know the answer to that yet.
Okay. Looks like the next question is about another side effect: abnormal sweating after 5 days of taking the second dose of the vaccine.
Mm-hmm.
Is that concern or?
Yeah, I would want a little bit more information. If it's just sweating, I would not be as concerned. But if you're still having a fever and the sweating is coming from the increased temperature, then I would definitely talk with your doctor about that. Or obviously, if the site appears red and that's growing any larger. I will say, I mean, there were, not that the fine print mentioned that the side effects lasted for quite that long. Usually it does end by about 3 days. But yeah, feel free to message me personally too about that. It's a little bit hard always just to take one symptom and try to come up with a diagnosis. So you can message me personally as well.
Joyce, can you also speak very briefly to explaining the vaccine reporting, adverse event reporting systems?
Yes, yeah. So it's, we've been talking about, all the adverse events that were reported in 20,000 people, but, what's the data when it reaches 2 million people or 20 million people? And that's what that vaccine adverse event reporting system is designed for, so that we can catch the 1 in a million cases of side effects or adverse events, and to see if they're related to the vaccine really is the cause for that. I think it's a joint venture by the CDC and FDA, I want to say. But yes, thanks, Peter. I like that. If for the person who is asking about that, there is a place to record that, so that the symptoms that you're experiencing can also help others who might be experiencing the same thing. I did also want to mention there is if you can't get enrolled in an official study, the NIH also has vSafe. After you get vaccinated, you can record your sort of own, you input your data basically into a website, and they'll collect that data as well, as long as you're, feel safe doing that. But if you don't know of an official trial that's going on, that's another way to participate in data.
All right, Joyce, Peter, we're 6 minutes after time. Are you okay to keep going? We have a few more questions. Are you guys okay to take a couple more? Y'all are the boss. You tell me when to shut it down.
Yeah, we'll let Joyce decide when to shut it down. I'm good.
We'll see when I run out of hard drive space with this recording. So, all right, question here from Debbie. Can people with, I apologize for my pronunciation of this. Can people with Guillain-Barré syndrome take the vaccine? Has heart disease, diabetes, psoriatic arthritis, cannot take regular flu shot?
The CDC does say Guillain-Barré is not a contraindication. They do address that specifically. So yes, it does look like you can.
Okay. And what about people with disabilities? Here, this question it says that I have spina bifida and also serious underlying conditions. Is it safe for me? Also, my parents are my caregivers and the current people that can get it, but there's not a place for me yet. We want to get them at the same time. What are we supposed to do?
So again, there's not been any clinical trial that was specifically looked at the vaccine in people with spina bifida, but so far there's no contraindications for it, and individuals with disabilities are at higher risk for respiratory complications associated with COVID. So typically they're encouraged to get the vaccine as soon as possible. Joyce, do you want to add anything to that?
No.
All right. Thank you. So from Elizabeth O, regarding the earlier question of people of color, but of the people that the vaccine didn't work on, were 10 to 12% of them Black? Also, same question for Asians.
Oh, I see. Okay, so of the 11, I think, in the Pfizer that did have COVID, was it predominantly in persons of color or racially diverse? That's a good question. I might have to look into that. Peter, do you know the demographic? I don't think that the document laid out
seeing the demographics of the people that were infected, or if I did see it, I don't recall it. I think that I can say pretty firmly that they absolutely would have reported it if one group was showing less efficacy. So they did report that the efficacy was the same across all groups. So if in those 11 people you saw it was all one particular ethnicity, they absolutely would have reported it. And that would have been in the headlines. Yeah,
that's true. And as far as the same goes for Asians, it looks like the question is, there were a representative number of Asians in the study, as there are in the state. So I think the state in America, the population of Asian Americans is a little above 5%, and in the studies they were about 4.7% versus 4.5. So they were right along the lines of being representative of the whole population.
Awesome. Just a couple more. This question here is about dogs. Is there any evidence that dogs can contract COVID and transmit it to their owners?
Great question. So we know that I've read a few isolated reports of dogs actually contracting COVID. Also, some apes have. I think there were some lions in a zoo that got it. There have not been any documented cases of animals passing it back to humans, though. But maybe if your dog is showing signs of COVID, don't let it lick your face. That's my personal recommendation, not medically based whatsoever.
Okay. All right. Let's see. And will there be a drive-through option for vaccines in Columbus?
I can answer that. We have offered them. We've offered them already. We're actually offering another one Friday. It's by appointment only. But again, Billy, this goes back to how many vaccines we receive, which is really a challenge. But we recognize this particular group, it's much more to their advantage to stay in their car instead of walking, a long way to get the vaccine. So really, that's why we're doing the drive-throughs, to reach out to this community, to this particular community.
Cool. Thank you, Daryl.
Mhm.
Does the red spot at the site of vaccination disappear over time?
Yes, it does. If it takes more than a week, I would say contact your physician though.
And one last, I think we're at the end here. I don't know how to pronounce this. It's an ANOBES, ANOBES. And if you can unmute, you had your hand raised earlier. I wanted to make sure. I don't know if you're still on the call actually. To make sure we got to you. I see your hand. Would you like to ask your question?
Maybe it's just a high five.
Okay. Well, I respond with a high five right back to you. So, okay, take that back. 2 more questions and then we will wrap it up. Where will this be hosted? Where will this video be placed? We will be posting this video on our YouTube channel. So if you go to YouTube and search for MercyMed of Columbus, this will be living out there. We did similar type meetings when we did our COVID-19 testing back in the spring of last year. And so it'll be posted there. We'll also put it on our social media page on facebook.com/MercyMedColumbus. And if you Google it, you'll find it. One last question for the panel, and then I think we will turn over to you guys for closing remarks. Again, a question about disabilities. It says there's no category for people with disabilities who have serious underlying conditions to register at any registration site or for their at-risk caregivers. Daryl, do you have any thoughts on that or any?
Yeah, we take them all. If they're 65 and older, we take them. We're not, there for a while we were asking about comorbidities. Now we're taking 65 and older, and we don't even ask that question.
Okay. Great. So hop on to the website again, Daryl, I'm going to put it in the chat.
westcentralhealthdistrict.com, and you'll see a red bar up there, and that's actually where you register for the vaccine, and you'll indicate your county where you live in.
Okay.
Thank you.
Good deal. Yeah, I'm so glad you joined. Thank you for being here. So just to repeat that, if you couldn't hear him, there's not an indicator, to your point, on the application to sign up, and no need for one. If they're 65 and over, they will be taken in. At this point, that's the group that's the group that'll be allowed to receive the vaccine. Did I get that right, Daryl? Did I say that right?
That is correct.
And then the last question, did COVID cause your mustache? No, I'm just a mustache guy. What can I say? Peter, Joyce, Daryl, Asante, everyone, thank you for joining us. Any closing words? Peter, Huwe, what you got for us?
Again, this is a kind of a very evolving situation that we've all found ourselves in. And in the course of the next few weeks to month, there might be another vaccine out that's a completely different technology behind it. It's a viral vector vaccine. And we don't know the stats of that yet, but we'll find it out. And if there's other questions that we didn't answer today or new questions that arise, maybe having to do with other vaccines that come out, then you should really bother Billy and get him to put together another talk.
Yeah, let me put, I'm through. That's a really good point. I'll put my email address in the chat, you guys. Just shoot me an email and I will not know the answer to your question. but I can go find Dr. Kim and Dr. Huwe, and we'll figure it out. But your feedback would be wonderful so that we can respond accordingly. If these things, if these types of interactions are good, we want to keep doing them. Dr. Kim, any final words?
Yeah, I think these vaccines actually do give us a lot of hope that there is an end in sight. It's not soon, but it's coming. And, if we really do, if we can achieve herd immunity and get, 70 to 80% of the population, either having contracted the virus or vaccinated, it could really, really change our lives again. So it's a message of hope. I think there's good things to come. So that's all.
That's great. We love you guys. We're going to go. And give us a holler if you need anything, okay? That's it for now. Bye-bye.